Hello. Good evening, everybody. Thank you, everyone, for joining us this evening for our Coding and Reimbursement webinar. I'm your host for this evening. My name is Dan McDevitt. I'm the chairman of the Community Practice Committee. I know how hard all of you work, and I truly appreciate you spending a precious hour of your day with us tonight. I promise we'll make this worth it for you. It's a fact that vascular surgeons work more hours than any other physician specialty. Your time and effort may be immediately appreciated by your grateful patients, but sadly, insurers have a different approach to recognizing your efforts. Coding your procedures is the key to proper reimbursement. Unless you learn how to speak the language of the payers, you will likely leave hard-earned money on the table. Tonight, we'll address coding and reimbursement to help you get paid what you deserve, so let's get started. First, I want to introduce our webinar operator, Jacob, who will share with us how to use the webinar features. And then I'll introduce our presenters and panelists, and then we'll open the webinar for questions. Jacob?
Thank you, Dan. And before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. At any time, you may adjust your audio using any computer volume settings that you may have. On the right-hand side of your screen, you will see the text chat window. There is a large window which holds all of your sent messages and a smaller text box at the bottom where you will type in your questions. To send in a question, click in the text box and type your text. When finished, click the send button. All questions that you submit are only seen by today's presenters. Your questions will be responded to in the order in which they were received and will be addressed at the end of the presentation. At the conclusion of today's program, we ask that you complete a brief post-event survey. Please take a moment to complete this survey as it will help SVS Community Practice Committee plan future web events. And now, back to you, Dan.
Thank you. Thank you, Jacob. We're joined today by our presenters, Dr. Sunita Srivastava, Dr. Fran Aiello, and Dr. Ravi Hasanadka. I'm going to move right along with the presentations, and I'm going to turn the microphone over to Dr. Srivastava.
Great. Thank you, Dan. I'm going to move ahead with the first slide. I have no disclosures. And then these are the session goals. And when you signed up for this webinar, you probably saw that each one of us are tasked with covering a certain amount of content. And so we'll get to all of this in the next 15 minutes. Coding tools are numerous. They're on the web. They're programs. I would encourage you to have a conversation with your coding and reimbursement specialist for your division or department specific to vascular surgery. If you want to venture out, we do have a tome called the CPT manual. This comes out yearly, representing the sort of updates in the CPT coding for the year. There's also additional material that's available through the AMA website. We have a CPT assistant article, and the purpose of this monthly newsletter is really just to clarify proper CPT sort of code usage or historical context. And this is also edited by members of the Coding and Reimbursement Committee, and Dr. Ravi is actually on the editorial panel for this. We do have annual changes that are made to the CPT codes, and that is available on an annual manual. There's also extensive software that you can get either through the AMA or through private sites that will not only handle the coding for you, but also link you to CPT Assistant, to ICD-10 codes. This Codeware Manager is very helpful, and your practice is probably already using this. And then, of course, I have to put a plug in for our yearly coding course. We have, a number of illustrious colleagues and colleagues in training who come to this course regularly to sort of see where we are with updates in coding and reimbursement and see what the issues are on a national and a local geographic level. Moving on. When we talk about sort of the currency, you may have all heard about the RVU, which is an acronym for the relative value unit. And this number, which we all are held accountable to so dearly on a monthly basis and yearly basis, really consists of three components. Our work, which is a physician time and intensity, which is about half of it. The practice expense, or the cost or overhead of the materials that we use, the malpractice expense, and then there isn't a geographic conversion factor because a certain procedure may be more expensive to conduct in one part of the country versus the other just based upon payers, maybe based upon equipment. The other fundamental concept to understand is the idea of the facility and the non-facility, because there are differences in the practice expense or the overhead. A facility is considered a hospital, ER, or outpatient clinic. Here, the practice expense is lower because the hospital assumes the overwhelming expense for the equipment. When you're working in a physician office or a freestanding unit or an OBL, it is the sort of practitioners or the group that are assuming the cost of the material. There are, moving forward, fundamentally there are two types of codes. We have trended towards this bundled code concept, and what that is a code that reflects the number of steps that are part of the ultimate successful procedure. So it represents an entire procedure and all the sort of necessary steps that are inherent to it. And so if we look at a lower extremity intervention, the work of the intervention includes a diagnostic portion, the vessel cannulation, the actual therapy itself, and the completion portion, and that is considered a bundled code. And this has been applied to a lot of vascular coding in the lower extremity, EVAR, CVAR, IVC filters, and the like. We do have still a number of codes that are unbundled or considered component coding. This is an older coding scheme where there were separate elements of work and value. So if you just do a diagnostic angiogram, you'll note that there's a separate code for sort of the access, the vessel cannulation, and then the diagnostic portion of the procedure. Peripheral stents are also, in certain vascular beds, are also considered unbundled. And one of the biggest mistakes that people make is they take a code that is bundled and unbundle it, because they go through we all dictate and we go through the steps of exactly what we did, and therefore we feel that there should be a code for every step, and there isn't necessarily that concept here. So when we look at endovascular therapies, again, we will be in these bundled codes be including in that procedure the selective catheter, the therapeutic intervention, the radiographic supervision and interpretation, whatever access you use, open or percutaneous, up to a certain French level, and then obviously there are other codes that can be used in addition to the main code, and those are considered add-on codes. Now with open procedures, it's a bit easier, and it's an older coding schema, but like if you think about a fem-pop bypass, the code for fem-pop bypass includes all the elements for a successful bypass. That would include endarterectomy, thrombectomy of your inflow or outflow, your completion angiogram, or a duplex study that you conduct in order to see the efficacy of your procedure. Other examples of interventions that are bundled, again, carotid stenting, IVC filter, and again, lower extremity. Now, it's great when you go shopping and you get a buy one, get one free, or buy one, get one 50% off, but it's more, disappointing when we see that when we do a number of procedures on one patient, that we are also subjected to a multiple procedure discount. And so what happens if you're doing a number of procedures on a particular patient in a particular session, what will get reported is the highest value RVU code, and you'll get 100% of that. Then all the other codes that are reported will be subjected to a 50% discount. The exceptions are the vascular lab codes, any imaging codes, and these are radiographic supervision and interpretation codes, say for TVAR, and then add-on codes. So these are codes that are added on to a base code. These are not subjected to the multiple procedure discount. The global period is sort of that time of physician work that is before, during, and after the procedure that involved the care, and that includes all the preoperative and intraprocedural care and the postoperative care for the patient. This global package also includes sort of getting consent and documentation of your review of imaging. There are procedures that have different global periods. So for some of our standard open therapies, EVAR and TVAR, those have a 90-day global. So there are a certain number of postoperative visits that are built into that code. We do have codes that have a 10-day global, and these are typically the minimally invasive thermal and non-thermal venous ablations. And then there are codes with 0-day globals, typically diagnostic and therapeutic interventions. And I had mentioned the site of service, which is the hospital or the facility and the non-facility. So the RVU is going to depend upon sort of where you're conducting your case. This is just to remind you that if you're in the facility, again, the carrier will only reimburse the physician side as opposed to the hospital, which receives the technical side for payment of all the supplies. If you're functioning in a non-facility and your practice owns or your ambulatory care center owns equipment and supplies, this group is going to be also reimbursed the technical side with a higher practice expense. And this is what we call the site of service differential. So, you can have different RVUs depending upon where you conduct your case. The physician and malpractice parts of the RVU are not affected by the practice expense. I'm going to move on to another fundamental aspect of correct coding, which is really everything that we give to our coders and reimbursement specialists are contained in our operative note. Some of you may belong to practices where you insert your own CPT codes or you dictate your own CPT codes, and that's sort of a group or practice decision. But the critical elements of a successful operative note include the pre-op and post-op diagnosis, and that would be helpful to use ICD-10 terminology. It's helpful to outline comorbidities and complexities, any microbiology results or pathology. It's very important to dictate who the primary surgeon is. And this primary surgeon needs to dictate the role of all the assistants that are in the case. It's helpful to also have the indications for surgery, sort of the complexity, because this will provide logic for additional modifiers that you may want to use for this operative case. And then the last thing is to describe your operative findings, because this may help you in justifying sort of a higher complexity case, and it may justify the use of the 22 modifier, which is a higher level complexity. It's important to get your dictations on time because our coders have only a certain amount of time in which to turn over the code, to present it to the carrier, and to get reimbursement. It's important to stick to the procedural detail. Billers are not physicians, and they're typically not nurses, and their understanding of medical lingo and local terminology is going to be limited. So try to stick to sort of the classic terms that are used. You can go to the CPT manual and look at a lot of the introductory language. Be clear about what tools you use and the location. Some people like to, interchange docking, limb, and extension, and we know that there are two very different things, but our coders do not, and those are separate in specific codes. Moderate sedation is separately reportable and would have to include a start and stop time if you do your own moderate sedation. It's helpful to use a standardized template so that you can prevent critical omissions. I'm going to move on next to surgical modifiers. There's a lot of information, and so I've decided to break it up. We have modifiers that we use in addition to our CPT code that tells our coders and our third-party payers sort of additional information. And these modifiers can be in the operative setting or same-day modifiers. They can be surgeon role modifiers where it explains my role, my assistant's role, or a co-surgeon's role. It can be a global period modifier if I'm doing an operation on a patient that I've already am in the global period of a fempop bypass, but now I need to take them back to do an iliac stent 2 weeks later. We have modifiers for those situations. And then there are also global package modifiers. These modifiers all are allocated different reimbursement rate. And there's software and there's a lot of information for this. We teach this, in our coding course, and I'm going to briefly go over some of the more common operative modifiers that many of us use. So the 50 modifier is really just letting the payer, and it's oftentimes a part of the software that we use, where it indicates 50% procedural discount for the second, third, and additional cases. And so it's not something that you necessarily would put, in your operative note. That would be something that your coder would have to input, or it may be automatically deducted in your coding software. The 51 modifier is I beg your pardon, the 50 is for the bilateral, the 51 modifier is for the additional procedure. I'm getting ahead of myself. So if there's some procedure that you do that is done on both the right and left side, we consider it 50able, indicating that it is a bilateral code, and you could use a 50 modifier. Some payers prefer that you actually not use that and bill each procedure separately, and they put the 50 modifier in themselves. It really just depends upon who the payer is. The next modifier, which is a 59, indicates that you are doing something that is different, that is a separate anatomic site, that is a separate procedure. And so this is a 59 modifier. You may do a FEMPOP bypass on one side, and if you're feeling really aggressive, want to do a contralateral femoral endarterectomy on the other. Well, the payers don't know. They may think that you're trying to do an ipsilateral femoral endarterectomy on the same side. So that 59 modifier tells the payer, no, this is a separate anatomic site at the same session as the FEMPOP bypass, and this is an anatomically distinct site. We also have national coding guidelines. And this is just an automated system that tells us what codes we can report together on the same day. And this was developed by CMS, and it's updated quarterly, and we get updates on this. And what the goal is it's really to eliminate codes that can be considered part of each other. So if we look at iliac conduit, and these codes are in columns, iliac conduit is 34833, and that would be in column 1. Open iliac exposure is its own code. If that's in column 2, it would eliminate, if you were to report both of them on the same time, there would be a CCI edit indicating that you could not report open iliac exposure on the same anatomical site as the iliac conduit because the exposure is considered part of the conduit. So this tells us sort of what codes are inappropriate to be billed at the same time on the same day. And there are columns, and it's a software program that can be used. And these are also, again, updated. Your coders know all about this. So the CCI edits are, again, published quarterly by CMS. They do use coding software. And, these edits may conflict with what's in the CPT guidelines or in the CPT book. So these are things that you're going to either have to dictate carefully, work with your coding and reimbursement specialist. You may get denials. You can appeal with references to the CPT manual, to the CPT assistant, and be armed when you have these denials. A common code that we come across is the unlisted code. And I used to think early on in my career in coding and reimbursement that this is like a great code because anything that I couldn't figure out a code for, I would use unlisted. This is a great deal of work for most coding and reimbursement specialists because this indicates that there is no CPT code that describes your procedure. And sometimes I feel like I am inventing a new operation, but most of the time, if we go back, we can think about sort of what our procedure is analogous to, and that's so the whole goal is not to find what doesn't match, but what does match. And so if you are going to use an unlisted code because the procedure that you're doing is very unique, it's not described by any CPT code, be prepared to submit operative documentation, be prepared to submit crosswalk codes or codes that most closely represent the work that you did in this particular case, and be prepared for denials or review and having to sort of, speak to people and write letters. So this will, consume a fair amount of time. There are some codes some procedures that we don't have codes for, and this would be some bypass codes that we do rarely. They don't have a CPT code. The staff lobectomy code under 10 is assigned the unlisted code, and currently arch branch endografting is as well. So, I think the best thing to do is to sort of sit down with your reimbursement specialist, your coders, and find out, what this particular code is being used for, how much work is it taking, and what could you use an alternative, or how could you fortify your unlisted code application to the third-party payer. Let's talk about some common errors. I sometimes will do a lower extremity intervention, spend 6 hours only to have accomplished not crossing the lesion, spent a lot of work, used a lot of equipment, and at the end of it all, what I'll be able to code for is a diagnostic angiogram. Because in coding and reimbursement, unsuccessful procedures are not reimbursed. Reimbursement is not based in the codes that are reported on not what work was attempted, but what was actually done. And so if you convert from a percutaneous procedure to an open procedure, say you're doing an EVAR, and you have to, unfortunately, convert to open procedure, you would not report the EVAR code. You would actually only report the open code for whatever aortic reconstruction you performed, aortic tube, aorta biiliac, aorta bifemoral. Another common error that I sort of alluded to earlier on in the talk was unbundling a bundled procedure. And so, looking at the CPT manual, talking to your coders, and making sure that you don't inadvertently do that, is helpful. It makes their jobs easier. And then the last thing is really to, take a look at your unlisted use and to see, if there actually is a code for the procedure, or work with your team about how to fortify and how to make your unlisted code application stronger so that you won't experience denials. And I really appreciate your time. I hope that I did not speak too quickly.
Hey, thanks, Sunita. This is Dan McDevitt again. I'm going to take the prerogative of the chair. That was a lot of great information. I want to grab a couple questions right now, and then we'll keep moving on. There also will be a chance at the end of all the presentations to ask questions as well. Jacob, could you just refresh everybody's memory about how to ask a question real quick?
Absolutely. And as a reminder, the text chat is located on the right-hand side of your screen. To submit a question, type your question in that small text box at the bottom, and when finished, click the send button. Again, please note that due to time constraints, our panel may not be able to respond to all questions submitted. And back to you, Dan.
Okay, thanks. The first question is code 34812-50. They're getting denials stating it's payable only for one. Can you clarify that, perhaps?
Yeah, in the coding course, we've had specialists tell us that they are getting denied. And so I think I would look specifically at your coding software and to see if it just if it just automatically takes out the 50 or it's not submitting it. I would talk to your third-party payer about that. Another thing that you could do, sometimes they ask you to list right and left for those specific codes that can be bilateral. That is an option. And then the last consideration would be a 59 modifier indicating that it is a separate and distinct site. So I would talk to your payer, to see what the exact reason is. And sometimes, it's the software that automatically sort of deletes the 50. So I would take a look at that as well.
Then the next question is, and I'm paraphrasing a little bit, but if the case is more complex, are you getting more reimbursement for it depending on how you code for it?
Well, that's a great question. So there is, an increased procedural service code, which is a 22 modifier. And basically you're telling the payer, hey, this was, lengthier. This patient was reoperative multiple times, that sort of thing. And I think that you really need to document. This is where, your indications for procedure, your preoperative pros, and also your findings at surgery, indicating the complexity, is really going to help augment your ability to get, additional payment for the 22 modifier. And I believe that it pays at 12 point. I think it's I don't recall exactly, because I have all these numbers in my head, what percentage more it is. But again, Sean Roddy talks about this all the time. You can advocate for high-risk coding behavior and, put in as many modifiers as you feel that you think you should have, versus taking sort of a more global approach and say, there are going to be some situations where this is going to be appropriate. Let's define those guidelines. Let's see what we've been paid for in the past with the 22 modifier and say, this is the kind of documentation that we're going to need as a group in order to advocate for this.
Okay, great. Thank you. That took care of some of the questions. Now, I'm going to move on in the interest of time to Dr. Aiello's presentation. Dr. Aiello, please take the floor.
I think Ravi's next. I can go. But...
Oh, okay. I'm sorry, I had the order out of. So the other Dr. Aiello, Dr. Hasanadka, I apologize for the confusion there. If you wouldn't mind taking the floor. Thank you very much.
So my section of the presentation is titled Fault and Claim Submissions Again, I have financial disclosures. For this session, I'll be talking first about appropriate documentation, because that is the big deal, paying attention to the details for coding. Then the most common cause for errors actually is typographical errors and demographic errors, so I'll dedicate some time to that. We'll talk about issues, and then finally what to do with denial follow-up. So for appropriate documentation, the main factor is attention to details. So for example, with correct side surgery documentation, it's important to get the right versus left correct to match your actual procedure you did, because otherwise that is a cause for denial. Even these minor things are one of the main reasons for denials. So as I touched on briefly already, CPT codes are codes for unilateral and bilateral procedures. For example, a bilateral extremity angiogram has a CPT code separate from the unilateral extremity angiogram. So if that particular differentiation exists for your code, then it's important to use the specific code. By a side, it's important that the CPT code side matches what you're referring to. Right, there can lead to a denial. Talking about ICD.
And Dr. Hasanadka, it sounds like your phone line may be cutting out there a little bit. Is there any way that you could switch to a handset phone?
Well, I'm on hands, so I don't know. I can move closer to my source, run down the stairs fast.
Either that or possibly disconnect and reconnect. Many times that is very helpful.
Any better?
Oh, that is much better now.
Oh,
so I'll let
okay.
you know if it continues.
All right. So, sorry about that. So for the ICD-10 codes, it's important they correspond to the CPT code. So that means using the correct ICD-10 code. So, for example, a coder may use admitting diagnosis that doesn't actually correspond to the CPT code of the procedure. For example, if somebody comes in with chest pain and you're doing a foot debridement on them, and then you're using the admission ICD-10 code, that will not clearly match up and get paid correctly. Also, the preoperative diagnosis is not always the right ICD-10 code to assign to the procedure, particularly if the operation changes due to findings for what's ultimately coded. And the next point touches base on what was on the prior slide, which is if the ICD-10 code refers to a right leg, but the CPT code coded has a left modifier, then that also will not get paid and denied. The ICD-10 code also needs to be as specific as possible. For example, if you use I-70.2 atherosclerosis of native artery of leg, that is commonly denied. But if you use .234, which adds right leg and ulceration of midfoot, that is more specific and therefore far more billable. So it's important to be most specific on those. The last point on the attention to details I'll talk about is the importance of the attestation, because that is very commonly forgotten in doing documentation. With electronic medical record, this can easily be done with macros, but again, oftentimes it's forgotten. In operative notes, it's important to say there's a statement about being present for the key portion of the procedures and available for the remainder, or the other option, if you're there the whole time, is to say you're there the entire portion of the procedure. So the other factor of appropriate documentation that's important is the clarity. And so in the operative note, it's important, really the S&I codes, to have the narrative justify the S&I code you're trying to bill for. So, for example, if you're billing a lower extremity angiogram in a patient with a preoperative CT angio, where the diagnosis was already made in that prior study, in order to justify billing for the S&I code, it's important to specify, for example, the angiographic images were required for diagnosis due to the CT angio being non-diagnostic due to timing of contrast or heavy calcification limiting accuracy, or if there is a change in patient clinical status, then that would justify billing the S&I code. Other aspect of that is findings in the narrative need to justify the interpretation. So when billing an aortogram, it's important to actually show you interpreted it by commenting on renal artery origins, aorta, common iliacs, external iliacs, etc. So that is the clarity in the operative note, and that's key for billing. The narrative also needs to describe what the CPT code is you're doing. So, for example, femoral endarterectomy 35371 versus iliofemoral endarterectomy 35355. Those are very similar procedures, but the difference is removing plaque in the distal external iliac artery, which many surgeons do. But in order to build a 35355 and get that additional work RVU, you need to actually say in the narrative that you removed plaque from the distal external iliac artery. Another kind of pitfall area is if in some standard dictations, you might refer to a quote-unquote graft that was used for your bypass, but the CPT code specifically refers to a vein bypass versus other than vein. So if you are just using a generic template on your operative note, you might be undercoding a vein bypass. So that's important to specify what you're doing to get those CPT codes. Next section is the most common cause for denials, which is typographical and demographic errors. This sounds a little too simple, but again, it's the most common cause for denials. So it's important to get the correct date of service. This oftentimes is a trouble if the operation starts and ends after midnight on a different day. As long as the dates of the billing and the procedure note match up, it's okay. Correct name is also important. This example I gave here of M. Ann Smith, she probably goes by Ann Smith and might be listed that way in your electronic medical record, but her insurance card says M. Ann Smith, so those have to match up. Same thing with addresses. They're not always correctly matching. Patient account numbers, birth dates, and again, getting all 5 digits in that CPT code correctly when they're being transcribed. Many of these applications, if they have too many blanks in them, will also, or be an incomplete entry, will be denied. And then illegible paper forms and faxes. If you're not using a computerized system, these forms are photocopied and faxed multiple locations before they get to the end, and smudges and copies of copies sometimes lead to errors in transcription. So moving on then to delayed payment issues, it is very important to submit a timely and correct claim in order to get paid quickly and appropriately. Typically, you have 30 days to submit those claims. The importance of a correct claim is that you are more likely to be reimbursed at the initial submission. Appeals are less likely to be paid, and appeals also waste your time and money in getting paid. So to try to facilitate some of that, coding softwares and tools do exist that can identify mistakes prior to submission. They are customizable to what it is you're doing, and it helps avoid typographical errors without photocopying a fax to a fax. Delayed payment issues are oftentimes carrier dependent, which is on the other end from your office. For government payers, sometimes that's related to congressional legislation being delayed, and therefore they're not paying in a timely fashion. It can also be related to the insurer investigating a claim or some delay in processing on their end. Along those lines, many states have prompt pay laws that require companies to pay a claim within a specific number of days, usually 30, or be subject to a penalty. For example, in Illinois, if you pay a claim, they pay a claim to you beyond 30 days, it's subject to a penalty of 9% per year, which is nice for ultimate payment. Coordination of benefits for patients that have primary and secondary insurances can also cause delay in payment issues because if there's a lack of additional documentation that's required. So the way to avoid that is you build a primary insurance first, and then you get the explanation of benefits from that and provide it to the secondary insurance company. The secondary insurance company is the EOB from the primary insurance company before processing its claim. Then for accounts receivable issues, this is involved with processing denials and ensuring payments are made. So the MGMA believes that the best performing group should have a 4% denial rate, which is a very high task to meet. In getting to that, it's important to review each denial because you can learn from your denials and try to improve in the future to avoid those. And again, sometimes they are simple corrections such as typographical or transcription errors that can be fixed quickly and lead to reimbursement. Note, some organizations only review denials if they are over a certain dollar amount. So you should check with your institution because you'd be getting a lot of denials you don't know about just because your organization is not addressing them. And there's also the receivable issue could be on the patient side. So there are pre-service estimates that can be provided for the patient so the patient knows their out-of-pocket expense before the procedure so they can try to plan accordingly and then pay after the procedure. So for denial follow-up, point to make here is don't write these off intentionally or unintentionally. Try to look through them, figure them out, correct them, correct the submission, recode and resubmit them. Sometimes this requires a letter of medical necessity, which is a simple thing to write to try to get paid. And again, the unlisted procedure code 37799, Dr. Srivastava has gone into more detail about in the prior talk, but just to reemphasize, speak to your coder to clarify the comparison code as internal crosswalk, because that is probably the key step in getting unlisted procedure codes paid for. All right. Well, thank you for dealing with my phone.
So we will transition into dealing with private payers, no disclosures. So in dealing with private payers, it is important to still understand the difference between private payers and Medicare and Medicaid rules. And that being that most carriers will use some element of Medicare rules, regulations, and policies to help create their own medical policies. In fact, as you say later on, they sometimes quote that they follow Medicare guidelines unless they have carved out specific exceptions for their own policies. We'll also talk about pre-authorizations and post-care denials. So under Medicare rules and regulations, one of the most important factors you can look into are the national and local care determinations, or LCDs. And these are mainly devised by Medicare administrative contractors who basically subcontract through Medicare to provide care and for patients in a certain geographic region, or whether it be a state or an entire region, depending on the patient population. The LCDs essentially provide medical necessity guidelines. In some cases, we'll break it down into CPT procedure codes and acceptable ICD-10 codes, as well as limitations to what you can and cannot perform based on their assumptions of medical necessities. The medical necessity guidelines are important because a lot of private carriers, rather than having this extensive list of CPT and ICD-10 codes, will simply write a few criteria that they deem are medically necessary for performing a certain service. Now, as we go into this, you'll see derivatives from Medicare. So in Medicare situation, if Medicare denies a patient bill, you cannot directly bill the patient themselves unless you have an advanced beneficiary notice. And what this essentially states is, and the patient has to sign this prior to the procedure, is that if Medicare does not pay, that they will. And what private carriers tend to carry instead of an ABN is basically a non-coverage service waiver. And again, most institutions do not go for this in advance, and at this point, if the private carrier denies it, you really have no recourse, especially with Medicare beneficiaries, and a lot of private carriers will follow the same protocol. And then lastly is prior authorization. Medicare on the website and everything else will usually commonly state that's not required for the vast majority of services. But what we've been realizing over the last few years is that more and more procedures are requiring prior authorizations. And most recently, you'll see that venous treatments, as of July 1st, especially in Massachusetts, will now require prior authorization for these procedures. So this is essentially what an LCD will look like if you go to the CMS website. It'll be divided by a geographic region, and you can look up old LCDs and new LCDs, and sometimes this is important in order to understand what has changed in the time intervals. From there, you can identify which LCD is pertinent to your practice, such as here you're seeing, near the bottom of the page here, varicose veins and lower extremity treatment. They'll tell you when it's going to affect, when there are modifications, and the duration of this code. And then here, like I said, you can see codes, or you can see medical necessity and limitations of certain procedures. Remember that the codes themselves are not going to be the only say-so that any carrier might have. It also depends on what they deem as limitations and medical necessity aside from the codes. And some policies will have something along the lines where they'll list the procedures that you can perform under, a sort of grouping of codes. And from there, they'll list a large proportion of ICD-10 codes are acceptable for as justification of medical necessities. The next one we go into for a lot of our patient population is Medicare Advantage plans. For all intents and purposes, these patients are still deemed to be covered by Medicare. However, they subcontract to a private insurer. The rub here is that the explanation of benefits or coverage or rules follow that private carrier. They do not necessarily follow Medicare. The ruling is that the private carrier has to provide all the services that Medicare provides. However, it does not stipulate that they can't create their own rules, regulations, and necessities for doing this. So in most cases, they tend to require more referrals, and the prior auths tend to be more extensive and a little more encompassing of more procedures. The coverage decision or coverage information prior to services must be discussed, and these patients sometimes have higher yearly out-of-pocket limits, which can limit their care at times. And again, while it says that you cannot charge more than original Medicare for certain services, a lot of institutions and a lot of practices will initially start by charging the same rate they would charge that private carrier. And this has been an area of contention in some institutions. And you'll see here's a plan from Harvard Pilgrim where it basically says that they follow Medicare guidelines from NCDs and LCDs. However, their procedures requiring PAs or prior authorizations is much more extensive than Medicare. So even though they have Medicare Advantage plans and they deem to be still in Medicare, the prior authorization process can be very different. Now, as we transition over to private carriers, they tend to have more policies and fewer coding lists. A lot of times they don't have that wonderful list of codes, although it can be there. So it's pertinent for the patients as well as some of the carriers to look at the EOB or explanation of benefits. And so what does that mean and how do we go through this process? Well, a good number of private carriers will use Interqual Change Healthcare, which uses what's called an Interqual Smart Set. What this is, and I'll show you a few examples, is basically a way to complete information as well as submit clinical information to the carrier for a service you want to provide. This is commonly reviewed by nurses who will then determine if the service or level of care is clinically indicated. Now, these criteria are updated continuously, and they are released annually. But even though they're only released annually, they can change the rules on almost a daily basis depending on what they see. The other one, excuse me, that you will commonly see is a pre-certification process, where it provides a full list of CPT codes for covered services, and each carrier will have their own way of submitting. In most cases nowadays, including Medicaid, we'll have an electronic submission process. And you can see this is very cumbersome. We're about to show now. You'll see that Interqual can be up to 10 pages long. This is, again, for venous treatments. We try to keep it consistent here. And it's about 10 pages where we have to check this information out. Usually, who's ever obtaining authorization will go through your notes in order to submit this data. And if it's not there, it's hard for them to submit it. Along these packets, oftentimes you will see explanations of all the coding they provide into there, because sometimes there are abbreviations and other exceptions. And you will occasionally see ICD codes that they accept, as well as PCS and CPT codes. Other ones that we just discussed is the carrier pre-authorization process. This is for Cigna, and I've listed the website here. You'll see that it doesn't always make a lot of sense as we look through this process. In this situation, for their basic standard plan, they do cover MOCA. However, they do not cover RFAs. I had failed to understand this process, but a lot of the carriers that I've evaluated over my last 2-3 years, it shows that a lot of these policies and pre-authorization processes do not follow a very consistent pattern. And this is just a sample table. A lot of institutions will have this. They basically outline through the prior authorization pods or those who obtain clearance for your procedures a list of all the carriers in that area and how we or the institution submits and obtains prior authorizations to do these things. Now, that being said, prior authorization is absolutely not a guarantee of being reimbursed. They may say yes to that, and then they may refer to their carrier policies as stating that this is a non-covered service, to which you're on your own. So what if you are denied? Well, there's a few things you can do here. First off, if it's a non-covered clinical condition, the eligibility issue, you have to review through the explanation of benefits. If it's truly stated in that they're not allowed to cover it, then you have little recourse with the insurer because they're basically giving you the outlines, even if you have a prior auth. At that point, you can bill the patient. However, if you have not had them sign either the ABN or the non-covered service waiver, then you're unable to do that. An example that I commonly give for this is we've had patients walk into our cardiology office who insist on getting an EKG because they have family members who've had heart attacks. Now, they have no real indication at that point to do it. And so if the ABN is not provided, we will not be reimbursed for that EKG either professionally or from institution level. And this is one of the more common ones we saw at institution before we started issuing these ABNs, or told the patients that they're not covered for this and they will have to pay out of pocket. So what if you obtain a prior authorization, but a few things occur? One, it's the incorrect prior authorization, which means due to a mistake or a change in procedure, so you got the consent to prior auth for one procedure, you end up doing a second one. So if you got the PA for the first procedure and you changed it, at this point you can request an adjustment to an existing PA. The recommendation is you do it during that hospitalization, certainly within 30 days, in order to establish this. And this is usually a more successful process. The more confusion comes into effect when the prior authorization is not obtained or not required. For instance, an example we had recently is angiograms. Angiograms are institution for one carrier, does not require a PA. However, if you subsequently do a procedure that does require it, which we found out stenting, however, of the lower extremity does require a PA pod, then the only recourse you have is to submit a retroactive PA and allow your CBO or your central billing office to know that immediately. However, this can be very challenging, and some insurers actually do not even allow a retroactive prior authorization. So lately we've undertaken the process of submitting a ton of codes when we do these sort of angiograms. The key is really to submit these changes immediately, during that same hospitalization, that same day, or if they're an inpatient, before they get discharged. Most institutions will allow you 90 days, some only 30, Medicare allows you 180. You can then go to a second level or to provider relations, and if you really think it's a bad payer habits, which we've had to escalate in our institution, you can then go up to, as far as the state insurance committee in order to establish a reimbursement model. All right. And then some of the national attention we've recently received has been regarding the price transparency requirements and the transparency in coverage. To my knowledge, neither of these are put into position as they're both being appealed, and I think one is in the legal system. The other one has had an extension due to requests by the insurers. Basically, the first policy it essentially states is that hospitals sort of have to let you know what things actually cost and what the charges are in order to keep price transparency and allow you to have a fair market evaluation and determine where you want to go based on what it's going to cost you for out-of-pocket expenses, co-payments, and insurance premiums. The second one, transparency and coverage, is essentially a way of each payer knowing what their insurance is actually paying for these services. If you have a bigger, it has certain requirements where it has to be more than X amount of payment plans, X amount of participants, but it allows you to determine what's going on and allows you to determine what your insurance will be paying, what your copay will be, and how that impacts the entire process. So the hard truth here, there are different rules and processes. They mostly will state they're CMS driven, but quite frankly, they tailor these rules and regulations to accommodate themselves, is what I've realized. Prior authorization, while we all feel good and cozy when we see that, does not by any means guarantee payment. So you really need to have your offices or your plans identify the coverage details, the EOBs, and perform, and the patients need to perform the due diligence. And again, we usually recommend getting the ABN or non-coverage service waiver assigned. Pay attention to claim submissions as you've seen previously. Any sort of error or technicality can just be that technicality. And there are significant changes on the horizon that we need to be cognizant of. But in essence, the patient is inevitably responsible if done correctly, which always puts us in an awkward position as a caregiver. That's it. Thank you.
All right, thanks. Those are great presentations. I'm going to open the floor for questions. And Jacob, can you again just remind everybody real quickly how to put a question in so everybody knows?
Absolutely. And again, as a reminder, the text chat is located on the right-hand side of your screen. To submit a question, type your question in that small text box at the bottom, and when finished, click the send button. Again, please note that due to time constraints, our panel may not be able to respond to all questions submitted. And back to you.
Okay, great. There's a question posed, and I think it's an excellent one. And Ravi, if you could address this. The question is about superficial femoral artery stenting. And the question is, to paraphrase a little bit, when you do that, when you do an SFA stent, does that negate all the other codes that you would have, such as catheter destinations, angiograms, imaging, et cetera? What are the rules on that? A lot of us will do a diagnostic angiogram and then decide to treat right there. How does that affect the coding?
Excuse me. With the SFA stenting, the interpretation, the S&I portion of the stent placement is part of the stent placement. So you're going to bill a diagnostic code, it has to be for the diagnostic portion you do before that. So that's typically a authorization from the external iliac or the common femoral rather than the...
Can I correct that?
Oh, sure.
So you, if you're doing an SFA stent, the diagnostic angiography associated with putting in that SFA stent or sort of lower extremity runoff is part of the SFA stent. Any completion angiography is part of the SFA stent. The vessel cannulation into the SFA or popliteal, which are considered one vessel, is part of that stent procedure. You can, if you've done a diagnostic aortogram or a thoracic aortogram or upper extremity, code for that separately because that's not inherent to the stent procedure. It is the same with, doing a PTA. So if you do a balloon angioplasty of the popliteal, the diagnostic portion of the limb exam, the catheterization, the ballooning, the completion angiography, and then any touch-up that you do in that area is all part of that balloon angioplasty.
Okay,
including the
great.
radiographic supervision and interpretation. Yeah, and it's the same thing with atherectomy. So you're taking the highest level of intervention that you've done in a vascular territory, and the RSNI, the radiographic supervision and interpretation, the work to cross that lesion, treat that lesion, identify that lesion, and do the completion and report it is all considered part of that intervention, and therefore is bundled.
Excellent. Yeah, I think that for that, and I appreciate the clarification, is can you ever append any other codes with that? Because I think, the impression is for a lot of people that once you do the SFA atherectomy stent, all other codes that you could possibly use are negated by that, but that's not entirely true, is it?
Only if it's in a different vascular bed, Dan. So if you do an SFA atherectomy and stent, which is the highest level of intervention currently that you can code for a particular territory, if you then go on to balloon angioplasty, a tibioperineal trunk, or a posterior tibial, that is a separate territory. You can report that.
Mm-hmm. Excellent.
Or whatever highest level of intervention you did for that, yeah.
All right, moving on, and Fran, if maybe you can address this one. Is there a difference in the coding between a cadaveric vein bypass versus a PTFE bypass graft?
Yeah, no, to my knowledge, they're both considered synthetic. I think the issue at hand here, the difference between the venous and non-venous coding is that we take into consideration with vein bypasses the time it takes to harvest that, which is why they have a higher value to them. If you're using anything else that's not in that situation where you don't have to harvest, which could be cadaveric or PTFE, then those fall into a synthetic category or non-autologous because it's not from the patient himself. And it's really a work process that is considered into this. It's not the expense of the device because that goes onto the, the DRG payments to the institution. So those would be considered under the synthetic process, if I remember correctly.
Okay, and Sunita, if you could address this one too, because it's sort of in the same territory as we were going through before. If you're coding an aortogram and a left leg angiogram with an atherectomy of the left SFA, can you sort of walk through whatever the coding process is there?
Sure, and let me just say you can code for diagnostic imaging if they're for whatever bed you're going to treat if there's no previous imaging. And, some carriers will say, CT scan and MRA within 30 days counts as previous imaging, so you'd have to check. So if you were going to, come from the left femoral, do a diagnostic aortogram, then do a runoff of the contralateral side or right leg angiogram, and the patient has no prior imaging within 30 days, and you identify an SFA lesion. You then cross the lesion, you treat it with the intervention of choice, you do completion angiogram, you see that everything is fine, you've not dissected, you have no embolization, you would code that as, your whatever access you did, your aortogram, you would code for a diagnostic lower extremity angiogram because you didn't have one before, and then you would code for the balloon angioplasty of the vascular territory you treated the SFA, the tibial, whatever, separately.
Okay. Next question. Again, over to you, Ravi. You're doing an angiogram from a radial artery approach. At what point do you cross second or third order vessels? Is it into the iliacs or is it into the femoral vessels?
That all starts all starts from the abdominal aorta. So, your first branch is the common iliac. Then, it doesn't matter if you started from the contralateral common femoral or the radial and you're coming from above. It starts from the aorta. So, first order is common iliac. Second order is external. Third order is the SFA.
Okay. And next question, and I'm going to send this over to you, Fran. How do you properly document an operative note when you have co-surgeons of the same specialty?
So this, I think the distinction here is a little more complex. So when it comes to co-surgeon, you both have to dictate a note, as opposed to assistant, where only one person dictates and you state that the other surgeon was an assistant surgeon. In both situations, if you have residents, if it's an IME and DME certified facility through the GME, then you have to state that a resident of qualified ability was not available to you, which is why you need a second surgeon. The area of confusion here comes into the fact that CMS typically does not allow the two surgeons of the same specialty to do co-surgeon. The CPT AMA process does allow that, however, through the modifier use. At our institution, we have not found CMS to deny that. So basically, if you're doing, a femoral fem-pop bypass, you need another co-surgeon in there because of the complexity, it's a redo or something along the caliber, then typically I would dictate one portion of it, maybe the harvesting of the vein, the proximal anastomosis. The co-surgeon would then dictate their portion of the note, which would probably be the distal anastomosis. It's hard to dictate the same portion that does not constitute co-surgeon status. But realize that CMS doesn't typically allow of the same specialty. The AMA and CPT process through the coding does. So that's where the confusion usually lies in.
Fran, I'm not exactly sure about that, and the way that we teach this in the coding course is that co-surgery to 62 modifiers typically only reported by two separate specialties. If you have someone of the same specialty and they do a distinct portion of your procedure, say they do a deep femoral harvest while you do a NACE procedure, you would report the NACE, but then the other person would be the assistant surgeon reporting and dictating a separate operative note for what they actually did. But you'd have to say in an academic institution that there's no qualified resident available.
So at our institution like this, it's been the fact that CMS makes that distinction, but the CPT manual in the back doesn't state that it can't be two of the same specialty. So we've been doing that and have been getting reimbursed for it to date, at least.
Okay. Good answers to that. I'm just going to keep it going a little bit. And again, Sunita, how can people, I guess, ahead of time find out if a code is bundled or not? How can they determine that?
You can query a code. Just Google it, and you'll often find information about the code. You can also, your coders and your reimbursement specialists will have a CPT manual, and you can actually look up the code. There's also coding software. The SVS had a great coding guide that I would use constantly, and I think there's, process in the works to reintroduce that. But, there are a lot of tools that you can use to see sort of what the code consists of so that you're sure that, you're not, unbundling a code if you have to report it yourself. But, you can also leave that up to your coding and billing, people. I would suggest meeting with them on a regular basis when you have denials or if you're curious, and to see sort of what the practice is.
And I'll throw this out there for the panel, and I'd like each of you to kind of comment on this. Do you think it's important for us as surgeons? I know a lot of us have turned our op notes over to somebody who does the coding for us. Do you think it's important for us to know personally how we should code everything?
I think there are some specialty or some divisions and departments where when you dictate your operative note and you go to addend it, you have to then, insert the CPT codes. And some people, surgeons actually dictate CPT codes in their operative note. I think that's a preference. I think you have to look and see sort of what you code, what you get reimbursed for, and what the practice is in your group, and decide collectively on, what to do.
Ravi, what are your thoughts?
I think I've been at different institutions where I enter the CPT codes into like a billing sheet or electronic billing sheet, and I've been places where they just look at my operative note and like harvest the codes from coders doing that. And I think it's really important if you're in that second group that you're still aware of what the coding is, because there's no guarantee to you that the coder is looking at everything and actually coding it the way you wanted it to be coded, and you might be not coding for everything you're supposed to be coding for. So usually the coder is more accurate than the surgeon, granted, but it's good to be involved with that process and make sure it's being done the way you want it to be done. So I think being active and meeting with your coders regularly, as Dr. Srivastava said, is a good idea, and that will help you in the future actually put in under the procedure section in the operative note all the important things to help them find them quicker as well, and then support it in the narrative clearly.
Fran, what are your thoughts? Hello? I'll just jump in. Yeah.
Fran just disconnected.
Oh, okay. Well, I'll jump in. And, I can tell you in private practice that I think it's been important for me to know how to code because it's helped me create better op notes that more reflect the coding that I expect. And then it also gives me some opportunity to, review what they're billing for me and see if I agree with it. So I think it's a good skill to have. Let me check.
Dan, can I add one more thing?
Yeah, sure.
If there are LCD or local coverage decisions or payment or policy issues that the members would like to have addressed, please feel free to go to the SVS website and look under sort of coding and reimbursement. There should be a couple of emails to Tricia Krishak or Mo Malik, and we will get your questions, answered, or at least, try to get back to you. I know this forum is limited and we can't get to everybody's questions, so I'm sorry about that.
Well, that's great. We're kind of at the end of the hour, and it looks like a lot of the questions that we've had have been answered. So I think it's probably time that we can move on. I'd like to thank you, Dr. Srivastava and Hasanadka and Dr. Aiello, for guiding us through this important topic. And I'd like to take 2 seconds just to say to everybody, please contribute to the SVS PAC. There's a proposed cut of at least 7% in our reimbursement for procedures starting in 2021. That's about, 10 months from now? And that's a minimum. So we're trying like crazy to get those cuts stemmed. We need your donations to the PAC so we can go to CMS and Congress and help alleviate this. There's really never been a better time to donate now because it's really critical. I mean, if you think about it, that's a huge pay cut for all of us to weather. Anyway, thank you, everybody, for attending the seminar tonight. There was a lot of good information. I know we covered it very quickly, and we'll like to do more of these in the future. Before you go, though, I want you to stay on for just a brief message from Jacob. Jacob, could you close this out for us, please?
Thank you. And with that, on behalf of Society of Vascular Surgery, I would like to thank you for your participation in today's event. A post-event survey will appear requesting your feedback. Please take a moment to complete this survey as it will help Society of Vascular Surgery plan future web events. This concludes today's program. Thank you and have a great day.